Hello, welcome back. We were discussing about pharmacokinetics and the parts of pharmacokinetics, that is absorption, distribution, metabolism, and elimination. We have already completed the absorption. Now we will discuss about distribution. For a review, pharmacokinetics means what the body does to the drug. So it's the what the body does to the drugs, and the parts are absorption, distribution, metabolism, and excretion. They are known as ADME. So today we are discussing about distribution. So in the figure you can see that there is two parts. One is pharmacokinetics and the pharmacodynamics. Pharmacokinetics and pharmacodynamics. And the next part here, the dose of drug administered. We have to give some dose of drug, then it has to be absorbed. So the drug concentration in system circulation. Yesterday in the previous class I have told that absorption means from the site of application to the bloodstream or systemic circulation. That pathway, that process is known as absorption. After absorption, it has to be distributed. That is drug in tissue of distribution. So it has to be distributed all over the body. Then a few amount or few part of the drugs concentration site of action. So if we are taking some drug and the site of action may be different from the site of distribution. Okay, sometimes the same site and distribution will be the same. When it is different, it has to move or it has to go to the site of action. There it undergoes the pharmacodynamic activity. That means the pharmacological effect of the drug, the clinical response by that drug. And the rest of drug should be eliminated. Before elimination, it has to be metabolized. Okay, so the elimination means drug should be metabolized and excreted. So this is the brief of the processes which occurs when we take a drug. Now distribution. Distribution means it's the movement of drug from bloodstream to the tissue. Movement of drug from bloodstream to other tissues. Absorption was the movement of drug from the site of application to bloodstream. From bloodstream to other tissues is known as distribution. So during the distribution, there will be a equilibrium will be attained. So the equilibrium between a unbound drug in the plasma and the tissue fluid. Here I will show the figure. Okay, so distribution, after drug reaches systemic circulation, it gets distributed to other tissues in simple way. Okay, now here you consider this as a bloodstream and some drug is there. So it reaches the bloodstream. From there it has to move to some area where it is distributed. So there is an equilibrium. Now the equilibrium is maintained. So according to the our plasma concentration or the concentration gradient, the drugs will move to the tissue region. So here a few amount is moved to the tissue where and the equilibrium is attained. Okay, the movement proceeds until a equilibrium is established between the unbound drug in plasma and the tissue fluid. So consider this is a tissue region. Again, a few amount will be eliminated. I have already previously told that a few amount of drug will be eliminated, that's metabolized and eliminated. So here the drug is a few amount in the plasma is eliminated. So again the our equilibrium is unbalanced. So the drug which is already distributed to the tissue will come back to the blood vessels. You can see here. So again the equilibrium is maintained. Here is 4, here is also 4. Okay, there is a parallel decline in both due to elimination. So in the previous slide there was 5 drug or 5 molecules. Now it is 4. So few amount is eliminated. And the equilibrium is maintained. There is a parallel decline in both due to elimination. So there will be a decline in the tissue and also in the plasma. And before going to the distribution in proper, we have to know some basic mechanisms or basic models of our body or basic concept about this distribution. So first about the compartment models. It is an hypothetical models used to describe the fate of drug in a biological system. So it is hypothetical model. So there are different types of model. One compartment model, two compartment model, and multi-compartment models. One compartment model means it is the simplest pharmacokinetic model, and it consider the body kinetically as a homogeneous unit. So the whole over our body is considered as a single unit. This is a one compartment model. So the assumes drug achieves instantaneous distribution throughout the body. So at the time of administration itself, it reaches all of the body. So this is an hypothetical situation. There is no such model or no such organism which has got that single compartment model, but it is a hypothetical model for studying our pharmacokinetic properties. That means the change in the plasma concentration quantitatively reflect the change in tissue. So there is a single compartment, the drug which is administered completely reaches the compartment. I will show here. See this. This is a model which shows a one compartment open model for intravenous administration. So consider the whole body as a single unit. So at the time of administration itself, it reaches all over the body. Same concentration will be reached all over the body. So one compartment model before administration and one compartment model immediately after administration. As it is a single unit, whole the drug will reaches the all area. So this is a hypothetical situation. We can't see this as a this in a normal situation. And this is the graph showing our concentration time gradient. In the absorption class, I have told when we give a drug as a IV injection, it will be the most or the highest peak will be in the initial stage itself. So the large amount will be there in the blood. Gradually it distributed to different areas, and also some will be eliminated or some will be metabolized. So the gradual concentration in the body will be decreasing. So you can see the graph. The concentration time graph is a monophasic response. So there is no any deviation. It is a monophasic response. For finding, for getting a straight line, we took log doses. Then we can plot a huge amount of doses, and also we will get a straight line. So it is a monophasic. There is no change in any deviation, or it has got a slanting position. Okay, this will be seen in one compartment model. Now two compartment model. When two compartment model, there is two bodies. When we divide the body into two parts, one is the central part and one is the peripheral part. Central part means the area which has got high perfusion, and the peripheral part there will be less perfusion. So when we give a drug, it goes fast to central part, and a few amount will be moved to peripheral part also. So it will be distributed. So initially it will go to central part, then it will go to the peripheral part. The drug distribute between central and peripheral compartment, does not achieve instantaneous distribution equilibrium between the two compartments. So it will take for an equilibrium. So initially when where there is a high perfusion, the blood of perfusion is there, the contents will move to the high perfuted area, that is the central part. Then from there it will move to the peripheral part, and the movement will continue till the equilibrium is reached. Here when we see the graph between the concentration and time graph, that the drug concentration time profile shows a curve, and there will be a biphasic response. So the initial there is a huge decline in the concentration, then a gradual decline. That means initially it will be distributed from the central part to the peripheral part. Later, when the concentration is when the equilibrium is attained, it slowly will reduces. This is known as biphasic response. And multimodal compartment. A multimodal compartment is a complex model, consists of one central and two peripheral or more peripheral compartments, two or more peripheral compartments. And here also there will be multiple phases for concentration of the, when we take the graph of concentration time graph, there will be multiple phases. So the drug distribution, so there is a drug, and where all it goes, it may be associated to receptors, so it can move to the receptors and for the action. Some may be plasma bounded, some may be bounded to the plasma in the blood itself. Some may go for storage tissues. In our body there are different types of storage tissues, and it can go to storage tissues, and some reaches for some the drugs for metabolism. So this is the regions where the drug can distribute. So when we administer a drug, first it should be absorbed to our systemic circulation. From the systemic circulation, it can move to different parts like receptors, plasma bound, some may go to storage areas, and some may metabolized in the body. Okay, so that's the basic of distribution. And again, in the technical term, we describe the distribution as volume of distribution. So how much amount of or how much volume is needed to attain or to accommodate the drug. This is known as the volume of distribution. The volume of distribution relates the amount of drug in the body to the concentration of drug in the plasma. So distribution means, I have told, is the movement of the drug from our plasma or blood to different areas or different sites, tissue. So this is the volume of distribution relates the amount of drug in the body to the concentration of drug in the plasma or blood. Okay. So it is a comparison or a ratio between the amount of drug in our body and amount of drug in the plasma. And also this is also a hypothetical situation. This is also a hypothetical situation. That is why we call it as a apparent volume of distribution. So apparent volume of distribution, the volume that would accommodate all the drug in the body if the concentration throughout was the same as in plasma. Actually, our system is a multiple phase system or multi-compartment system. Our normal human being or normal organism will be having a multiple or multi-compartment system. But for finding the values or finding the volume of distribution, we consider the body as a single unit. That's why it's known as an apparent volume of distribution, the volume that accommodate all the drug in the body if the concentration throughout was the same in the plasma. Okay, so we consider the concentration of our plasma and our body is same, and the total amount or total volume needed to accommodate those drug is known as apparent volume of distribution. Describes the amount of drug in the body as a multiple of that contained in the unit volume of the plasma. Okay, and we can calculate this volume of distribution. Volume of distribution is denoted as V, D or capital V itself. So it's the amount of drug in the body divided by its plasma concentration. Normally it is expressed in liters or liter per kilogram body weight. Okay, it will be expressed as liters or liter per kilogram body weight. It is the amount of body drug in the body divided by amount of our plasma or its plasma concentration. Okay, when we calculate the volume distribution, we will get different values, and there are some assumptions. When the volume distribution is low, it means it is less than 5 liters. 5 liters means it will be mainly in our vascular compartment. We know that our blood, total amount of blood in our body is about 4 to 6 liters. So if the volume of distribution is less than 5, that means the drug is probably in our blood itself. Okay, the drugs they will be seen mainly in the vascular compartment. The examples are heparin, warfarin and furosemide and all. So these drugs will be, majority of time they will be in the blood vascular compartment. So the volume of distribution is very less. When the volume of distribution is intermediate, that is about 5 to 15 liters. 5 to 15 liters means the drug will be in the extracellular fluid. So our total body volume is 42 liters. Okay, total body amount is 42 liters. So if it is intermediate, which means 5 to 15 liters, then it is considered that the drug is in the ECF, extracellular fluid. Mainly gentamicin and amoxicillin all have the intermediate volume of distribution. When it is high, that means more than 20 liters. When the volume of distribution is more than 20 liters, so the drug is mainly in the tissues. Okay, mainly in the tissues. So that means the drugs who having high volume distribution can reach the tissues very fast. So they can move to the tissues very fast, like ethanol, theophylline, digoxin, imipramine and chloroquine. They can move very fastly to the tissues, or the concentration will be very high in the tissues. Okay, now the factors which affect the volume of distribution. So I have told volume, the distribution means the movement of drug from the blood circulation into tissues, and the volume of distribution is the amount that determines the ratio of drug in the body to the its concentration, plasma concentration. So there are different factors which are related to the volume of distribution. They are lipid solubility, ionization at physiological pH, plasma protein binding, affinity to tissue proteins, difference in regional blood flow, pathological conditions and physiological conditions. So first, the lipid solubility. Lipid insoluble drugs do not enter the cell. Like during our absorption, I have told all the biological membrane is a lipid bilayer. So when the drug is lipid soluble, it can easily cross the membranes and reaches the cell. So when the drug is insoluble, a lipid insoluble drug, it do not enter the cell. So the volume of distribution will be corresponding to the extracellular fluid. So it cannot move to the cells. So it lies in the extracellular fluid itself. Those are like the examples like streptomycin, gentamicin. The volume of distribution will be 0.25 liters per kg. Okay, the majority of them will be in the extracellular fluid itself. Ionization of the drug. Again, like absorption also, in distribution, unionized drug will be lipid soluble and they can cross the membranes. Weakly acidic drugs, which is unionized in the acidic medium. So weakly acidic drugs, they will be unionized in the acidic medium. So the absorption will be very high in the acidic medium and also the distribution also very high in the acidic medium. Same way, weakly basic drugs, they will be unionized in the alkaline medium and the absorption will be, or the distribution will be very high in the alkaline medium. Plasma protein binding. So plasma protein binding means in our plasma we have got different types of proteins. Okay, some drug has affinity or their property of binding to this plasma protein. So if the drug is attached to the plasma protein, then the majority of time they will lies in the plasma itself. So the volume distribution will be less than 5 liters. So the drug has an affinity to bind to the plasma protein. So you can see here there is a plasma protein and some drug is attached to it. So it is in the bound form. Some will be in the free form. Some will attach to the plasma protein and the rest will lies free in the plasma. Okay, and an equilibrium is attained between both this bounded and free form. So every time there will be an equilibrium. So if the one of the free or one of the bounded drug is moved to tissue, then the free form will attach to this protein. Okay, a free drug will be there, a plasma protein bounded drug will be there. Free drug means available for the action, metabolism and excretion. So the plasma bound means it will be difficult for moving from the plasma to different site. But if the drug is free means it can move freely through the blood and goes to tissues, or it can go for excretion, it can go for metabolism, or it can do its action. So when it is metabolized or excreted, few amount will be reduced. So from plasma bounded will become free and the equilibrium is maintained. And the plasma will, or the bounded drugs will act as a reservoir. So it will be a reservoir. When the few amount of the drug is moved from the plasma, from the reservoir, corresponding amount will come out. And again, the acidic drugs binds to plasma albumin. And mainly there is two type of proteins in the blood. One is albumin and the other one is glycoprotein. So the acidic drugs binds to plasma albumin. Example, aspirin, warfarin, sulfonamide and all. And the basic drug binds to alpha 1 acid glycoprotein. Alpha 1 acid glycoprotein. So these are the two important plasma proteins in the blood. One is albumin and the other one is alpha 1 acid glycoprotein. The basic drugs like propranolol, lignocaine, quinidine, chlorpromazine all will attach or all bind to this alpha 1 acidic protein or acidic glycoprotein. The clinical significance of this plasma bounding. They are the first thing is it acts as a temporary reservoir or a storage site, which I have already told. And high plasma protein binding means which has got a longer acting property. So as long it lies or as long it is bounded to the plasma protein, it will be resolved or it will be stored for a long time. So it has got a long acting property. And the other important thing is the hemodialysis is not possible. So if there is any toxicity due to this high plasma bounded drug, the hemodialysis will not be possible, because during hemodialysis we can't dialysis our albumin or alpha 1 acid glycoprotein. The proteins will not be filtered during the hemodialysis. So if it is attached to this hemodialysis, or if it is attached to the plasma protein, then it will be difficult for hemodialysis. And when there is an alteration in plasma protein level, it can lead to toxicity. So if there is any alteration in the plasma protein level due to any diseases or physiological conditions, it can lead to toxicity. And the plasma protein binding is a capacity limited and saturable. Capacity limited means if a plasma protein has a property to attain or attach 4 or 5 drug or 5 molecules of drug, then the 6th molecule cannot be attached to that protein. That is saturable. So it has got a saturable property. If a protein has got 4 sides and 4 molecules can attach to that protein, the 5th one will be left over. It cannot attach. Only when one of these is moved from the attachment, the 5th one can come and attach to the protein. So it is capacity limited and saturable. And also there are some drug interactions. That means if we are giving 2 drugs which has got a plasma protein binding capacity, and one has got more affinity, so the one which has got more affinity will displaces the other without, or which has got low affinity. Okay, so the low affinity drug will be freely moving in the blood, and the high affinity will attach to the protein. So it has got some drug interactions also. See the examples. That is displacement reaction. Here you can see, consider here this white box. There was a white box here, and some drug or some type of molecule is attached, already attached to that, and we add another drug. So it will displace the other one, and the new drug will attach to that molecule. The previous one is not attached. Okay, it leads to toxicity. So there will be freely available of the first drug, and it causes toxicity. Example is salicylate replaces tolbutamide. Salicylate replaces tolbutamide. Tolbutamide is a drug used for diabetes. So when the patient is on tolbutamide, and when there is some pain or something, he took salicylate. So the salicylate is a highly plasma bounding drug. So it attached to the plasma protein, and it displaces the tolbutamide, already attached tolbutamide from the plasma. So the tolbutamide, there will be free amount of tolbutamide in the blood, which causes hypoglycemia. Again, this salicylate tolbutamide replaces warfarin. So these both has a property to displace the warfarin, and warfarin will leads to bleeding. Okay. Affinity to tissue protein, the fourth property or fourth factor, affinity to tissue protein. So some of the same as the plasma protein bounding, some drugs has got affinity to some specialized cells in the body. Some type of drugs has got a specialized affinity towards some drug in our body. So that drug will accumulate in that certain tissues. The drug get accumulated in certain tissues, and again, as plasma protein, this also acts as a reservoir. Cellular, for example, cellular reservoir due to affinity to tissue proteins. Here the digoxin is a skeletal muscle. Digoxin has got a affinity towards a skeletal muscle and heart. So when we give digoxin, the majority of drug will be distributed or will be stored in the skeletal muscle and the heart. And again, it can lead to complication of heart also. Same way, chloroquine has a affinity towards the cells in liver and also in the retina. So they will be precipitated in liver or retina. Fat as reservoir. Some drug has got affinity towards a lipid. That means fat. So they will be highly lipid soluble drugs like thiopentone, sodium. Bone. Some drugs access reservoir will be bone. Persistence of effect will be long, and after exposure will cease. That means tetracycline, cisplatin, lead and arsenic, they all have a high affinity towards the bone. Next is transcellular reservoir. So some spaces between the cells like aqueous humor, chloramphenicol has a affinity to the aqueous humor. CSF, cerebrospinal fluid, amino sugars, and sucrose has high affinity to CSF. Endolymph, which is seen in the ear, octagrenic acid, so it has got an affinity to that. Then pleural fluid, imipramine, methadone, they all have affinity towards the pleural fluid, so it will be accumulated in the pleural fluid. So this is the as tissue acting as a reservoir. Again, keratin, skin, the griseofulvin. Griseofulvin is an antifungal, and the skin itself is a reservoir for this griseofulvin. Now, the significance of this tissue reservoirs is an increased therapeutic effect in certain area. So, this has got a positive features and also negative features. As a positive feature, these, as I have already told, chloroquine has an affinity towards the liver. So, when there is a hepatic amoebiasis, when we give chloroquine, it will be more effective. So, the drugs, all the drugs will go to liver and it will kill the amoebas. Okay, again in the griseofulvin, so it will reservoir, the skin acts as a reservoir. So, when we are applying the griseofulvin in the skin, it is very effective for the fungal treatments. And the negative effect is the toxicity. So, it can be stored for a long time and it can have a action for a long time. So, the toxicity also increases, chance for toxicity also increases, but it has got some positive values and also negative values. Example for toxicity is fluoride in teeth, the fluoride. So, all the normal our toothpaste all have fluoride, but when we take some excess amount of fluoride, or when the amount of fluoride we ingest is very high, it will be deposited in the teeth, and which leads to destruction of teeth or malformation and all. Next important feature is or factor is regional blood flow, the movement of blood. So, it is a basic concept that highly perfused organ will get more drug accumulation. So, highly perfused organ will get more drug. Here in the picture you can see the high perfused areas like a kidney, heart and brain. So, when we apply a drug or when we give a drug, first they will be moving to the high perfused areas like brain, heart and lung. Then only it moves to the low perfused areas like skin, skeletal muscles and adipose tissues. Okay, this is a normal situation or a usual situation. Now, the next factor is pathological conditions. So, in some pathological conditions also varies this our volume of distribution. So, when there is edema or ascites, it can lead to fluid accumulation. So, the increased volume distribution of hydrophilic drugs, that means in our body there is an excess amount of fluid when there is ascites or edema. So, the water soluble drugs can accumulate more during this period and it leads to toxicity. In hypoalbuminemia, hypoalbuminemia means I have already told that albumin is an important plasma protein where the drugs are or the acidic drugs are attached to it. So, when there is hypoalbuminemia due to some diseases, kidney disease or some pregnancy and all, the albumin level in the body will be reduced. So, at that time the drugs which are ready to attach to the protein will decrease. So, the protein binding will be decreased. And the alpha 1 acidic glycoprotein is an acute phase reactant also. It can act as an acute phase reactant. So, if there is any acute situation in the body, it can the alpha 1 acid glycoprotein amount or the concentration will increase. So, plasma binding will increase. So, the drug which you administer will attach to this alpha 1 acid glycoprotein and the free amount will be reduced. And some physiological conditions which also determines our volume of distribution. In neonates, the water content is more. There the 70 to 75% of the total body weight is about water, and they have got ECF is 40% of the total body will be ECF, extracellular fluid. So, water soluble drugs like aminoglycosides are very dangerous for these neonates. When the protein binding is reduced, the free drug which can lead to toxicity. When the protein binding is reduced due to some physiological conditions, as I have already told, like pregnancy and all, the protein binding or the protein amount will be reduced. So, the protein binding will reduce and the free drug will increase in the body. So, it can lead to toxicity. The drugs compete with the bilirubin for binding with albumin. So, example is that in neonates itself, the drugs compete with the bilirubin for binding with the albumin. So, Bilirubin also has got a binding to albumin property. So the drugs will compete with the bilirubin, and the bilirubin normally they will attach to protein. So in neonates, when we give some drugs like sulfonamide, it will displaces the bilirubin. As I already told, this protein binding is a saturable condition. So the sulfonamides can displace the bilirubin. So when the neonate is having jaundice, and if we give sulfonamide, it will displace the bilirubin, which leads to kernicterus. Kernicterus is a situation where the high amount of bilirubin reaches the brain and causing some reactions. In elderly, already there will be reduced body mass, reduced body water, and decrease in serum albumin. So all the changes will be seen. That means we have to take, or we have to consider the age of the patient when we administer a drug. So in elderly, usually we reduces majority of the drug, we reduces the dose. Because of that, the body mass will be less, the water content will be less, and also the serum albumin also will be less. So there is a high chance for toxicities. And again, in pregnancy, there is a situation of hemodilution. So the water content in the body will be increasing. Hypoalbuminemia, the albumin level will be reduced, and also increased alpha-1 acidic glycoprotein. So when we administer a drug, we have to consider, when we give a drug to a pregnant woman, we have to consider all these factors. There is hemodilution, hypoalbuminemia state, and also an increased amount of alpha-1 acid glycoprotein. So we have to modify our drugs when we give to these pregnant women. And finally, we have to know some physiological barriers in the drug distribution. So we are distributing the drug has to move from the blood to the tissues. So crossing the tissue, there are some barriers, physiological barriers. The first one is the blood-brain barrier. It is made with the endothelial cells and glial cells. Endothelial forms a tight junction, and the glial cells form a protective layers. And also it has got some efflux transporters, P glycoprotein. There is a transporter, a type of transporter in the blood-brain barrier. It is a protective barrier against the harmful xenobiotics. Xenobiotics means the externally giving any substance. The P glycoprotein will expel or efflux the harmful substance from the brain to outside. So it not allow a harmful substance to enter the brain. So this is a physiological barrier. But in inflammatory conditions, this barrier will be more permeable. So inflammatory conditions, the drug will be, the blood-brain barrier will be more permeable. Another important barrier is placental blood barrier, but it is an incomplete barrier. It is not as our blood-brain barrier, but it is an incomplete barrier. So lipid solubility through passive diffusion, main role. So the lipid soluble drugs can passes by passive diffusion, so no energy is needed, and the main role of our placental blood-brain barrier is passing of substance from the mother to baby or to the fetus. So the lipid solubility, that means the placental barrier has got a lipid solubility or high lipid solubility. So due to that, main lipid soluble drugs can pass very passively to the fetus. General anesthetics, sedatives, opioids, and all, when we administer this to a pregnant woman, it can freely move to the baby. And active transport like glucose and aminoglycosides are moved by active transport through the placental barrier. Again, one more thing in distribution is redistribution. Okay, the highly lipid soluble drugs initially distributed to the organs with a high blood flow. So this is a summary of all over our factors which we have already discussed. The distribution depend upon the blood flow, distribution depend upon the concentration of the drug, distribution depend upon the affinity of the drug, and also affinity of the tissues. So the highly lipid soluble drugs means they will be very fastly absorbed or will be distributed. So if the area is having, or the blood or the substance has got an affinity to some place which has got high blood flow, means the initial distribution of a large amount will be distributed to that area. Then only the initially a huge amount, about 95% of the drug will be moved to that high perfused lipid region or high affinity region. The rest will be moving to less vascular and bulky tissue. So later only that the 5% will move to the bulky or less vascular areas. So when the plasma concentration falls, so the free amount, the free drug is present in the plasma, it will be eliminated, few will be eliminated, few will move to the action. So the concentration will decreases. At that time, the drug will withdrawn from the hyperfused area. So again, it is acting as a reservoir. So fastly they will move to the hyperfused high lipid affinity region. Then when the concentration decreases in the blood, they will come back from the hyperfused area. Okay. The example is thiopentone sodium. Thiopentone sodium has got a high redistribution. So when we administer a 100% thiopentone sodium, 95% will move to the tissues or the fat cells. Okay. Later, when the concentration in the blood reduces, they will move from the fat to blood for action. And to summarize, volume of distribution is the volume that accommodate all the drug if concentration throughout was same as the plasma. That means the when we consider our body as a single unit, and the amount of or the volume needed for accommodating the drug, that is known as the volume of distribution. And I have described different factors which affect this distribution, and also its significance of each factor I have already discussed. So that's we will stop this discussion here. Distribution. Hope these presentations are helpful for you. You should read your concerned topic in the textbook, then only you will be getting more idea about the pharmacokinetics. This is the basic. For studying pharmacology, you should study the basics of absorption, distribution, metabolism, and excretion. And in the exam point also, these all are very important. So I hope you are reading your textbook also. Okay, we will stop here. Thank you. Stay home, stay safe. Regards, Dr. Rahul. Thank you.